The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Calling all pediatricians, family physicians, and advanced practice providers. The 47th Annual Common Problems in Pediatrics Conference is coming June 3rd and 4th, 2025. The best part, 100% virtual. Get the latest updates in pediatric care, hear from top experts, and earn CME and MOC2, all from anywhere in the world. Whether you're looking to sharpen your skills or expand your professional network, this is the event you don't want to miss. Register now at aaputah.org events. See you there. Welcome back to the Virtual Curbside. This is the week where we get to ask questions, and we're very fortunate to have Dr. Tara DuPont back with us on the podcast this week. Welcome back, Tara.
Thank you for having me. I'm excited to be here again.
Well, we have a couple of interesting questions, so I look forward to being able to chat a little bit. Do you have any disclosures in the meantime?
As it turns out, I no longer have a disclosure.
All right. Well, then let's get started. Question number 1. In our nursery, babies who may have risk factors, particularly prematurity, are screened in a car seat to make sure they maintain their oxygen saturation before discharge. How well established and standardized is this test? Does the length of the test matter? If, for instance, a family lives 10 minutes from the hospital, does a baby need to tolerate being in a car seat for 90 minutes, or would a shorter period be safe? Or is the test a proxy for stress tolerance that goes beyond just car rides?
I think car seat trials are absolutely fascinating. And up until recently, we had very little data to support or refute their benefit. I will say most NICUs around the country do a car seat trial. Everyone seems to do it just a little bit differently. Some places it's just a 30-minute car seat trial. In Utah, most centers do a car seat trial for as long as the car ride is, up to about a maximum of 3 hours, and then recommend families that they stop every 3 hours if they're driving back to their home a long distance. I think that the question when a baby doesn't pass a car seat trial is more so why didn't they pass, especially if they're discharged from the newborn nursery. Now, in Utah, we're at a little bit of altitude. There might be a low level of pulmonary hypertension going on and lower level of oxygen. And we can question whether or not that needs to be investigated. Like, is there another reason why the baby didn't pass the car seat trial? I think that's worthy of investigation for a newborn nursery doctor. However, what I found interesting is there was a study that was published about 2 years ago in 23. And they looked at a major hospital system that just stopped doing car seat trials altogether and then looked for adverse events up to 30 days. And this was the Kaiser Permanente hospital system in Southern California. I believe they had about 400,000 babies in this cohort of infants. They found no increased risk for infants when they stopped doing the car seat trial. So I'm not entirely convinced that this is a super helpful test for families in going home based on the evidence. However, I am going to say that many institutions do it, and therefore I tend not to go against what the institutional belief is. I do, however, think it's something that should be questioned.
You know, it is an interesting question because these babies who are going home from a well newborn nursery may not have ever had a period of constant monitoring on an oximeter, and this may be the first contact we've had with the baby desaturate. So, you know, as you point out, the question we should ask ourselves then is why is the baby desaturating? And in Utah at altitude, could it just be that that's just the way it's going to be? But I think it's always incumbent on us to also say, is there something else going on?
100%, yes.
This question has a part 2. On a similar note, if a baby doesn't pass a car seat in the nursery, they are often retested in a car bed device or a recumbent car seat instead. If a baby goes home in a recumbent car seat, should a baby pass a car seat test in the office before transitioning to a normal sitting car seat? And let me make that a two-part question. The question as it stands, but also it seems to me that if a baby fails a test in a recumbent car seat, it's basically like failing an oximetry test in a bassinet. And what should we do then?
Yeah, I think if you have a baby that failed, I'm going to put quotes around that, a car bed test, then that makes me wonder, what is the baby doing when they're in the bassinet, right? So yes, I think that warrants further investigation. Now, again, in Utah, a ton of our babies wind up being discharged home on oxygen. They need it for a couple of weeks, maybe a month or so, just until their lungs open up, their pulmonary vasculature opens up enough to really get enough oxygen to keep those sats up. So I do think there is something to that, but I personally have to admit that I don't entirely understand the car bed trial, number one. And then I think the other question is, as they grow bigger, do you need to retest in a car seat? I think it depends on how stable the baby is and what the underlying etiology might be. So sometimes we get like a trisomy 21 baby who's a little hypotonic at baseline or another type of syndrome. They might have a hard time maintaining their musculature, their strength, or their tone to keep their head in a good position to provide, a good open airway. And I think that's a developmental question to answer.
Excellent. And again, as with the first question, for the initial testing, this may be the first time we've looked at a baby on oximetry, and I think clearly invites at least a little reflection.
Yeah, definitely. I think looking at tone, looking at lung status, looking at cardiac status are all important things to consider.
Yeah, perfect. Okay, last question. This is a fairly straightforward. What are the implications for feeding a former preterm infant? For instance, do things like introduction of solids and whole milk need to be adjusted for gestational age?
Yeah, I love this question. There's not a lot of strong evidence for much in post-discharge nutrition. I do think that everything should be adjusted for prematurity up until at least 2 years of age. And that includes introduction of solid foods. When we think about what a baby needs to do to get through solid foods, they need to have some degree of truncal tone, and your neck muscles need to be strong enough to support feeding. So I actually typically recommend babies don't start with solid foods until a closer to 9 months corrected age. So if you're talking about a 24-weeker, that's going to be close to 1 year from their actual birthday. Introduction of whole milk, the same thing. Not only do I think that's important from a developmental standpoint and their ability to digest the food, but from a nutrition standpoint, most solid foods, especially if you're talking about foods like rice cereal or oatmeal, often your starter foods are very low in calories. So if you have a baby that's struggling to gain weight, like a lot of our preterm infants are, giving them a low calorie rice cereal to fill up on might not be the optimal thing to do. Whereas giving them their transitional formula, it has a lot more calories and a lot more protein in it that's going to help with long-term growth.
And do we know anything about what happens with gut maturity based on gestational age versus just time navigating?
Yeah, I'm not able to quote the literature on this. I'm sorry. But like everything in the baby, just because you're born early, it doesn't miraculously mature right away. And in the gut, if anything, we think that it might mature slower. We know that because being in the NICU and all of the fun antibiotics that we give and our lovely hospital bacteria, we really do a number on the microbiome. And so those babies are at a little bit of a disadvantage when it comes to gut maturity. Did that answer the question?
Helpful.
Okay.
It does. Anything else that, as you've reflected since we last spoke, anything else that you'd like to share about?
No, I think we hit most of the highlights.
That's fine. It'd be wonderful to find a time to talk again sometime. This is very, very interesting and very helpful. I think this accomplished pretty much what we were aiming to do. So thanks so much for your time and your expertise. And we hope to talk to you again sometime.
Wonderful. I'd love to do it again. This was a lot of fun. Thank you.
Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design thanks to Paul Wirkus, who also composed the theme music. See you next time.